Good morning, everyone. Welcome. Thank you for joining us today. My name is Melanie Chasteen, and I'm the Director of Community Engagement for the Texas Campaign to Prevent Teen Pregnancy. I know we have always have a lot of familiar faces on our webinars. Next slide, please. But for those who might be engaging with us for the first time, the Texas Campaign to Prevent Teen Pregnancy, we are a nonpartisan, nonprofit organization focused on reducing unintended teen pregnancy, really through four key ways. The first, through research and data dissemination. Second, through advocacy for effective public policies. Third, through strategic collaborations, and last but not least, through training and events such as this one. We have the pleasure of working with a number of stakeholders from across Texas on our mission, and also stakeholders throughout the United States. Next slide. Today's webinar is part of our symposium programming, which we unfortunately had to cancel. It was scheduled for April, but we were able to transition most of the programming into a virtual format. Each month there's a theme. We are wrapping up this month's theme, and you'll see here what we have scheduled for June, and then the next slide has our July sessions. All of the information about these webinars can be found at txsymposium.org. Excuse me. We hope that you guys will continue to join us. Next slide. I'd like to give a big, gigantic shout out to our sponsors who have been just so wonderful and supportive as we transitioned our in-person event into this new format. So we definitely want to give them credit, and we appreciate them so much. So last few things here, next slide, is I feel like we're all experts on webinar technology now, so I probably don't have to really go over this very much, but you guys are all muted. I know this says use the Q&A function. We've been using the chat function a lot more, so you're more than welcome to use both of those functions if you have questions or comments. You should see them both at the bottom of your screen. And the presenters may answer some questions as they're going along, but we'll also save time at the end of the webinar for questions. The one question I get asked a lot is about the slide deck, and we are recording this, and we will be sending out the video along with the evaluation once the session is over. And we do hope that you will complete the evaluation. The evaluation will also pop up on your screen once we end, so it's an easy, super short, easy way to do that evaluation. If you are seeking continuing education units, you must do the evaluation. Next slide. So a quick word about our CEs that we are required to tell everyone is that we do our CEs through the Texas Department of State Health Services Continuing Education Service. Only participants who listen to the entire webinar live are eligible, and we will get those certificates out to you within 30 days of the webinar. Next slide. A reminder to please do the evaluation if you want your CEs, because it is required. And last but not least, next slide, please. Here is a list of the CEs that we provide through the DSHS office. The Texas Campaign also provides continuing professional education through the Texas Education Agency and community health worker units through Texas DSHS Community Health Worker Training and Certification Program. And there will be a place on the evaluation where you can check which CEs you are seeking. So now I'm going to pass it over to the presenters. And while I do that, I would like everybody to please pull up your chat box and put in your chat box the field that you work in. You know, you're a social worker, a counselor, nurse, a physician, etc. Let the presenters know where you are coming from.
Thanks, Melanie. It's great to be here. This is Dr. Maria Monge, and I have the privilege of presenting with an amazing family nurse practitioner who is an adolescent medicine trained specialist also, Marcy Keefe. And we today are going to be presenting this webinar on Parts Matter, Basics of Sexual and Reproductive Health for LGBTQ Adolescents and Young Adults. I start the vast majority, actually all of my talks on these topics by talking about my my position of privilege that I have in life and also in this work that I do. So I am a white cisgender heterosexual female who really doesn't have the lived experiences of my patients, and therefore find it really important that as I'm talking about these topics for people to realize that as I'm doing that, it's really not my lived experience, but it is what I'm observing and what patients are reflecting back to me and then sharing from that perspective. So everything that I do in this space of sexual and gender minority health, I come at through a lens of recognizing that this is not my own story to tell, but I'm here just to facilitate a discussion about these things. All right, so we will, and just to start, it looks like we have a variety of different persons on the webinar today of all sorts of different professions, and it is amazing, and it's great to see you all. This is, I feel very fortunate to be able to present to such a variety of people. So today our objectives that we're going to try to get to, we're going to talk about recognizing the importance of creating safe spaces to foster conversations about sexual and reproductive health with all adolescents and young adults, discuss contraceptive options for gender diverse adolescents and young adults, and then identify key principles of screening for and prevention of sexually transmitted infections in LGBTQ adolescents and young adults. Oh, and finally, this is one of Marcy's specific areas of interest is pre-exposure prophylaxis for HIV prevention in this population. So by tuning in to this webinar, I have assumed probably a preliminary, and hopefully not too big of an assumption, a preliminary knowledge of sexual and gender minority populations and terms, but just to remind everybody and to get everybody onto the same page, a brief review of definitions that we use frequently in this space. Gender identity is a concept that really defines who I am and who I see myself. Gender expression, on the other hand, is how I present myself to the world. So who I am and who I present myself can be two different things. And sometimes that is a little confusing for people when they're seeing someone across from them and they say, hi, my name is so-and-so, my pronouns are he, him, and his. And you look and they have pink hair, earrings, and nail polish. And in the United States especially, we have such a very binary definition of our gender roles, gender expression, that sometimes comes into conflict, and for cisgender people, it is very difficult to understand that gender identity and gender expression may not be equivalent. When we refer to sex, we're typically referring to the sex assigned at birth, which is my biology, and the way that I like to explain it and talk to it with patients is I call them your gonads. So that's going to refer to testicles or ovaries, typically in the vast majority of patients. And then sexual orientation, again, a completely separate concept than gender identity and gender expression, is who I'm attracted to. And this can be wide-ranging and really depends on the person, and it can also change over time. So we move to a discussion now of why do we have this topic? Why is this something that we're even looking at? So why does this matter?
Okay, so I'm Marcy Keefe, I'm a nurse practitioner, and I work with Dr. Monge, which is quite an honor and a privilege, and I too echo her sentiments about sharing this experience that is reflected to me through my work. Statistics, most of these have been taken from the Human Rights Campaign. Compared to their cisgender peers, gender diverse youth more often report sexual debut before the age of 13. People who identify as lesbian have a higher rate of pregnancy than their heterosexual peers. Compared to their cisgender peers, more gender diverse youth report using substances prior to their last sexual intercourse. Compared to their cisgender peers, gender diverse youth are more likely not to be using reliable contraception. Adolescents who have sex with both same and opposite sex partners are at greater risk of engaging in high-risk sexual behaviors than those who are sexually active with only same-sex partners. Sorry, I'm just reading these, but it's the only way to really do this. And a few more statistics. If current trends continue, 1 in 6 gay and bisexual men will be diagnosed with HIV in their lifetime. Certain populations are even more significantly impacted, with current trends predicting 1 in 4 Latino and 1 in 2 Black men who have sex with men diagnosed with HIV in their lifetime. Bisexual men are less likely than gay or heterosexual men to get tested for HIV, leading to increased risk of infection. And though we aren't really specifically talking about HPV today, it is important to note that bisexual people are less likely to be screened for HPV, which is associated with increased risk of multiple types of cancer.
All right, so we're going to dive right in now into really thinking about how do we start a conversation with adolescents and young adults about their sexual and reproductive health, especially in this space where people are already feeling fairly vulnerable when they are a sexual or gender minority. So we really would like for you to use the chat box function and help us come up with or reflect to us ways that you've found or that you think would be helpful in initiating these discussions. And outside of having everybody in a room where people are having a conversation and raising their hands or not raising their hands, I think that using the chat box is the best way that we can go about that. So the question here and the response that we're looking for is, how would you in your practice or in your experience, how do you create a safe space for vulnerable patients, i.e. Sexual and gender minority patients, to discuss sexual and reproductive health, something that sometimes doesn't actually come up, interestingly, in the context of typical visits?
So one person has said to be candid and non-judgmental, which is perfect. I think demonstrating non-judgmental behavior towards all of our minority clients is extremely important, knowing that that might be something that they have experienced in previous medical or health and education encounters. Establishing group agreements. Display my pronouns, set ground rules with the students that include respect and inclusivity. Use non-gender terms when discussing condoms, external, internal, that's perfect. Establishing group agreements. I'm guessing that kind of means sort of rules or terms to be respectful of other people that could be in the group. But if I'm wrong, please let me know. Ask questions, open and honest discussion, and ask youth if they have had any sex ed discussions, and let them guide the discussion. I think that's a very good approach. Normalize conversation around sexuality, since the stigma outside a safe place is high stigma. Definitely true. These are all really great responses, by the way. Hoping to help bring more adolescent-friendly and gender-diverse services to our clients. This webinar is timely. Most importantly, maintain a non-judgmental approach and let the adolescent guide the interaction. So it kind of seems to be the theme from the responses so far is refraining from being judgmental and demonstrating non-judgmental, could be language, body language, and also letting the adolescents drive or guide how the interaction goes.
I would just add, as we let adolescents kind of, how would you like me to address? Oh, that's great. So how would you like me to address you? That's perfect. Just kind of opening the space up for how do you see yourself? What do you use as opposed to what I think you want to hear? Sometimes we have to give the adolescents and young adults permission to even go there. And so I think that sometimes we have to initiate the conversation, but not in a close-ended way, but instead opening up the space for more discussion. Because this is such a topic that has high stigma, as someone pointed out, in the general public, I think it is really important that people realize that we're actually inviting this conversation. And the other part of that is make sure you have time for this, right? So the last thing in the world that you want to do is start the conversation in 30 seconds and be like, oh, just kidding, we'll have to do that next time. Because that's not authentic for anybody, but especially in this situation where harm could come from actually not letting people express what's going on. So we'll continue with our tips here that we have.
Okay. Of course, ensuring confidentiality so that your client understands that they have the safety to share with you without their information being divulged to people that it could cause harm back to them. Open body language. I think that this is sometimes underestimated and not talked about, but, the image I can think of is, I don't know, something maybe I've experienced as a person when you go into a provider's office and there's a very tall, sort of intimidating provider standing there in a white coat standing over you. It doesn't make you feel like you want to be vulnerable and share things. It might be things you don't want to tell someone who you feel might shame you or judge you for them. Using gender neutral language. So things like someone mentioned using external, internal condom instead of male or female condom. People who become pregnant, rather women that are pregnant, just they, them as pronouns, who is your partner, then rather than do you have a boyfriend or girlfriend. So those are just some examples of some gender neutral language. Body first language are things like when we talk to clients trying to use words such as, or say things like, when you have sex, is it penis and vagina, or whatever their terminology that they like to use for their body parts, rather than, are you sexually active with males or are you sexually active with females? So trying to use body parts rather than people language. And inclusivity reminders. This is something Dr. Monge reminded or told me about earlier this week, which I thought was really cool. And I haven't done this before, but need to. So when you're talking to someone, even if they are a cisgender person and identify themselves as heterosexual, when you're talking to them about reproductive and sexual wellness, they may assume that the person that they're interested in or that they're dating is, because they present themselves as male, that person has the body parts of a penis, or so kind of reminding that person that might not be the case. So like to be prepared and be open to how they might protect themselves in any given situation, depending on body parts, rather than how that person presents themselves to the world.
And interestingly, I'll just add one more thing to that, is sometimes I find myself in visits with adolescents who identify as gender diverse, and we're talking about reproductive health, and they will say to me, oh, I don't need such and such, whether that be birth control, whether that be, aggressive kind of STI reduction, like harm reduction and prevention, because, I'm dating X. And I said, well, that's interesting, because X doesn't necessarily have those parts. And so even for adolescents who identify as gender diverse, sometimes they actually forget that other people too may not have the parts that they would think that they do. So it's been fascinating, because really that adolescent brain development in this space is so really important to think of, and to just keep you grounded in that. You assume that when patients are identifying differently, that they also realize that other people could be different as well, but that's not always the way that adolescent brain development works. So we just have to sometimes remind them of parts that they have and maybe their partners might have. So we'll start with a case study, and this is Joe. So Joe is a 16-year-old transgender male who's been coming to clinic for life-affirming gender care for 11 months. He comes to clinic with his mom, who is supportive and affirming. He sees a therapist regularly for his depression, and with regular therapy visits and fluoxetine, which is medication for depression, his mood has markedly improved. Currently, he is taking medication for menstrual suppression, which was started about 1 year ago, and testosterone, which was begun about 6 months ago. So while having a confidential conversation with Joe, he tells you that he has recently been sexually active and is interested in birth control. So we're going to start this conversation with the fact that testosterone is not reliable birth control. And this may or may not be what adolescents that you come into contact have heard. And so testosterone in and of itself can lead to menstrual suppression. Not always, but it can. And so sometimes that gives patients a false sense that they cannot get pregnant. So we then have to have a conversation about what we would do.
Anytime you see Homer Simpson, this is your opportunity to enter comments in the chat box. So if you have any questions that you might ask Joe with this information that you've been given by him, what are some things you might ask him? What would you want to know about how you could help keep Joe safe? Okay. Are you interested in any form of birth control? Very good question. What type of sex do you have, and who is your partner? That is a really great question, because it is very gender neutral. So we can't assume anything about what parts Joe uses of his body to be sexually active. What are some reasons that you are wanting to birth control? So I have a better way to give you the options available to you. Okay. So maybe they want birth control to prevent pregnancy. Maybe they want birth control to not have periods or not bleed. Those are good questions. All right. So some probing questions you might ask are, do you feel safe? Did you feel safe when you were sexually active? Because we do know that sometimes people that are minorities are more vulnerable to exploitation or abuse or trauma. What do you call your body parts, so that you can have a clear way to have this conversation, so you don't offend them by calling their body part something that they really find dysphoric if you use certain words. And then when you have that information, you can ask them, what parts of your body do you use for sex? And sometimes I might just tell people, well, some people use their mouth for sex, some people use their rectum for sex, and some people use and when you know their terminology, you could say vagina, their internal organs, their front hole, whatever words that they choose to use. What parts do your partner have? What parts does your partner have? And do you protect yourself against pregnancy? And if so, how? So maybe they've used a condom of some sort. Maybe they use a different method to protect themselves against pregnancy. Another answer is, what parts do your partners have? What are your past experiences with condoms? ask about a reproductive life plan. Do you want to have a child in the next 12 months? And are you interested in birth control? The questions are being asked. So someone is asking, is there another chat box? I'm not seeing where questions are being asked. The chat box I'm in is currently empty. So I don't think you can see the questions, only we can. So if you want to answer the question that was on the previous screen where Homer Simpson was, that's the question. And you can answer in the chat box. So I don't think your chat box will show anything. Okay, you're welcome. All right, so Dr. Monge, do you have anything to add to that? I think really affirming like what language they use for their body parts is important, and then normalizing that any of these body parts, any parts of the body that people sometimes use for sex, so they don't feel like they can't say one thing because you're going to find it horrible if they say something that you don't expect.
Yeah, I think that we've hit some of the big things for me. And the reproductive life plan, I think in all of my conversations about contraception is really important. Interestingly, I think a lot of times when patients who identify as gender diverse, they have uteruses and they're on masculinizing hormone therapy, a lot of times people assume that they don't want to have biologic children. That assumption has actually been shown to be incorrect in multiple studies. It's not necessarily that all do, and certainly the vast majority of times I ask that question, which is with all of my patients, just because when we're starting hormones, like there's a big conversation about fertility, but we can't assume what people's reproductive life plans are. And so absolutely, if someone is thinking that they want to have a baby within the next year, perhaps a long-acting method is not necessarily what would be in their best interest at that point, though for some people it can. Someone also mentioned about STI protection and understanding what methods of contraception will protect and which will not. So and just emphasizing that contraception is not protection against sexually transmitted infections in any way. And that's for any person, whether they are sexual gender minority or not. So these are, just underscoring that we're really talking about parts, and the more that you can use that language, I think that the safer people feel to talk about what they're doing. This next slide, I just put on here for emphasis, but if a person has a uterus, there is a potential for pregnancy. And that's, again, kind of going back to testosterone. But this is where oftentimes for me, it comes up that people will say, well, I'm not having sex with someone who I would get pregnant, and because I'm attracted to women, for example. And then I look at them and I say, well, it turns out that there are some women who have penises. And they look at me, they're like, oh, you're right. So we really, this is just standard practice for me, that I talk about reproductive potential pretty much all of the time once I know that somebody is thinking about or is sexually active. So the question that may come up for you is, I'm trans, do I need birth control? As in, like, not asking for it, but if you find yourself in the situation where a lot of you are going to be in, which is in a social work situation, in a therapeutic situation, this may just come up as a point of conversation and not necessarily as, I want you to give this to me, i.e. birth control. And so there's the answer, maybe. And it depends on the parts that your partner has, and what you're doing with those parts. So I am going to review now for you different contraceptive options and the considerations that we have when we're talking about this in a gender diverse population. So like most adolescent medicine specialists, we are really, really big fans of LARCs, or long-acting reversible contraceptives. They are the most effective form of contraception. I actually say that the implant, the etonogestrel subdermal implant, is even more effective than having a tubal ligation, interestingly. People are often surprised. The so these are really the most effective forms that we have. They are long lasting, up to 10 or more years with a copper IUD, for example, and they're user independent, meaning once they're in, they work and you don't have to do something every day. Now, we have a whole special consideration section of these contraceptives for gender diverse persons. So as we go through each of these methods, I'm going to talk just briefly about how these can be different for people who who don't identify as cisgender. So bleeding side effects are actually a really big deal for many of our patients. If they've gone from menstrual suppression and they haven't been bleeding for 3 years, 4 years, and then suddenly you introduce a LARC, especially something like a copper IUD, which notoriously has a bleeding profile that a lot of patients don't love, or an etonogestrel subdermal implant, which also can have very unpredictable bleeding. You may take someone who's been very happy with their bleeding and take them to a situation where they're having a lot of bleeding, and that's extraordinarily dysphoric for them. On the other hand, something like a levonorgestrel IUD, especially the ones that are higher dose, like the Mirena or the Livetta, those have such a nice bleeding side effect profile that they may never bleed if they get those put in, which is often very welcome. Now, the next thing that comes up is the procedure for insertion. So if we're talking about LARCs, really the one that rises to the top for this is the subdermal implant, because it's quick, it's easy. I tell patients you're in and out within 10 minutes. And it's just, it doesn't involve an internal exam. You don't even have to look at the genitals. It really is a nice option for many of our patients. The biggest thing with LARCs, and this is in the general population too, and not just in our sexual and gender diverse patients, is the cost and availability. So if a clinic doesn't necessarily have access to low cost LARCs, then this may be cost prohibitive in some situations. There are certain plans or certain Medicaid forms where this is a plan exclusion. And so we wish that, as everybody does across the state, of course, we wish that we had a little bit better access. And then finally, the ease of use and discretion is really something that for a lot of trans persons who have uteruses, if they carry around, for example, a package of birth control pills, that's going to out them really quickly. Versus if, on the other hand, they have a LARC, there would be no way that somebody would know that that was there unless they were asked about it. So really for discretion, I think that LARCs are a great option for people. Marcy, I don't know if you wanted to add any comments about that in particular.
No, I think you summed it up pretty well.
The next form, so if a LARC is not something that the patient's interested in, or they're thinking about it, or you have to order it, or it's not immediately available, injectable medroxyprogesterone acetate, which is also known as Depo or Depo-Provera, and this is what a lot of people will know this as the shot, or they'll know it as Depo, quote unquote, but what it is progesterone in a high dose that's given every 4 to 12 weeks. And the reason I have 4 to 12 weeks is for pregnancy prevention, it's really 12 weeks. However, for a lot of our patients, they will bleed. So if we think about the bleeding side effects, I will often actually dose this more quickly. I give it in some of my patients, especially at the beginning of using this medication, every 4 weeks to just try to get bleeding under control, and then I space it out over time. I find that works pretty well. There is no procedure for insertion on this. You come in, you get a shot. It's quick, it's discreet, and it tends to be inexpensive. If a clinic stocks it, it may actually be more expensive than sending a prescription to the pharmacy, having someone pick it up, either give it at home or bring it to the clinic to be administered. I used to have a lot of trepidation about patients giving injectable medications at home like I am, and then I've been in this gender space for so long that everybody gives injections at home, men and women, and so I no longer have that same trepidation. So prescribing this for home use is not even something that I wouldn't consider, and can be very effective. Progesterone-only pills, are something that we often use for bleeding suppression. So we start a number of patients on this just to try to get menstrual kind of bleeding under control, and it works pretty well for that. But it's not very effective in pregnancy prevention, and therefore it is not something that we would recommend unless there is a contraindication to one of the other forms, or that's just what somebody insists on after we've gone through everything else. Again, in terms of discretion, it's not really that discreet when you're carrying around pills. They are pretty inexpensive depending upon what you use. You don't have to have an exam of any sort. And the biggest thing that you have to do is take them daily at the same time, because if you don't, the side effect of not taking these medicines every day at the same time is that you bleed, which again, as we've discussed, as I said before, can be very dysphoric for patients. And then finally, the last kind of option that we have if we're talking about anticipatory contraception is methods containing estrogen. Of all of the patients with uteruses that I take care of who identify as gender diverse, I would say less than 5% are on a method that contains estrogen. So this would be different than what we see in our typical cisgender populations, where the majority of people on birth control, though we wish it was different, are on, for example, a birth control pill. This is not what we see routinely in this population, and part of it is just because the idea that they would be taking estrogen, which is not something that they identify with for their life. They don't want to do that. It also carries a risk of DVT, which is a blood clot in the leg or the lung. And so you have to make sure if you're going to be starting these that they don't have any contraindications to be on these medications. They're very available, and so that is a nice thing. And you can usually do what we call extended cycling, where you don't take breaks off of, for example, the pill, patch, or ring. You just use it continuously, and that can be a pretty good way to control bleeding. And finally, I would be remiss if I didn't remind everybody about emergency contraception. And levonorgestrel, also known as Plan B or generics, is available over the counter to anyone. And fortunately, we did a study a couple of years ago of how available it actually is in Texas, and we found that over half of pharmacies in the state of Texas that we called, and we called 800 and some pharmacies in the state, had some barrier to getting over-the-counter levonorgestrel as emergency contraception. That's huge, whether that be they asked for identification, whether that be they said they couldn't sell to someone under the 18, which is not true, whether that be that it was behind a counter and not easily available. All of these things are barriers to people obtaining Plan B, and frankly, Plan B brand name is $50 in Austin. The generics can be as low as $20, just FYI, so that's good for people to know. There is a prescription only that is more effective and slightly more effective in different size diverse bodies, and is also effective for longer, up to 5 days. That's ulipristal, but you do have to have a prescription for that one. So the question that came through about the progesterone-only pills versus not very effective in pregnancy prevention. The reason why is because if you're taking progesterone-only pills, the dose of progesterone in those pills is very, very small, and it does not reliably prevent ovulation. Actually, it doesn't prevent ovulation in the doses that are used in these pills. So you're only relying upon two mechanisms to prevent pregnancy, and the biggest one is just thickening of cervical mucus. And so if it's not taken daily at exactly the same time, there can be, the cervical mucus can thin enough to allow for sperm passage. And because this isn't enough to prevent ovulation, you're actually not going to, you're not going to get the same reliability versus the combination estrogen pills, and patches and rings, which do prevent ovulation, even if they're not taken exactly perfectly. They are much better than the progesterone only pills at preventing ovulation. And user error is definitely a big consideration. A lot of these patients are going to be taking medication every day for something. So there's there's some routine that's already there and it won't be de novo, but we just find that really trying to steer people towards LARCs is really just so much better if they're not planning on having children in the next 12 to 24 months. Yeah, and the LARCs, just to go back to why they're so effective, is they have like multiple ways that they're preventing pregnancy. They are high, especially the implant is high enough dose that it's preventing ovulation. You're also getting a cervical mucus thickening. And then you also, because of the progesterone dose, will thin the lining of the uterus enough that it's not really hospitable for implantation. So there's a number of mechanisms at work there that really have the LARCs rise to the top of the things that we want to use. So Joe, just kind of concluding with him, he says that he was sexually active once. His partner used an external condom from start to finish. There was no oral or anal receptive or insertive sex. He was up for routine STI screening and decided to get an injection of Depo-Provera or medroxyprogesterone acetate for pregnancy prevention and also for menstrual suppression. He had been on an oral medication, but switching to this for him seemed better because of the more effective pregnancy prevention. And we scheduled follow-up for him to continue to engage in conversations about overall sexual wellness. So if there's any other questions about that case, please feel free to type them in here. We can get to them at the very end. All right.
Okay, so case study number 2 is Jada. Jada is a 19-year-old transgender female who comes in for routine care. She lives at home with her parents. She drives and is not currently working and goes to community college part-time. She feels well and is having increasing confidence in herself as she is seeing her therapist regularly, and she has started gender-affirming hormones. Jada tells you that she has recently been thinking about exploring a few dating apps that her friends have had good success with. She would like to have screening for sexually transmitted infections, but is really not ready for any kind of examination. Fact. So screening for sexually transmitted infections can be very discreet and examination is not necessarily needed. I really like to tell all my patients, I sort of like to explain to them how gonorrhea, chlamydia, syphilis, or HIV are transmitted and through what body parts they can be transmitted through. So for example, I might say gonorrhea and chlamydia could be transmitted through oral, penis or vaginal, cervical, or rectal sex, and then ask them, would you like any of your body parts tested? So kind of explaining things beforehand and then let them know. And then I like to tell them, you can just go to the bathroom, you can pee into a cup, you can do your own rectal swab, and I'll just swab your throat. So that sort of eliminates any fear of, because I might just say, no, I don't need those, because they think that you're going to make them have to have an exam for those tests. So kind of eliminating that fear might open the possibilities for testing.
And I will add that not so long ago, and I still remember probably 15 years ago when I was in medical school, 20 years ago, I mean, only 10, no, a long time ago, I had an attending, actually, someone who was training me say, well, if we have to do a urethral swab, they'll stop doing whatever, quote, high-risk behavior they were doing because it will hurt. And so it turns out that all that does is make sure that that patient never gets tested again. So if what we've learned in the adolescent medicine world, caring for adolescents and young adults, is you increase access to these things, and then they become more comfortable with having them done. And eventually, if and when they need exams, that becomes part of what you're doing as opposed to something that's seen as shaming.
Agree. So another Homer Simpson chat box opportunity here. What gender neutral questions can you ask to better understand her risk for STIs? So what things might you ask Jada to gain further understanding of how you can best keep her safe and healthy? And it's okay if some of them are the same as you asked Joe. And I also like to tell people when I'm offering STD testing that I like to explain that HIV and syphilis testing are done through the blood. And so that way they don't have any questions about how those are also tested for. Okay, so a few answers. What are the parts of your sexual partner? What things, are you having any type of sex without using STI protection? So that is a really great question. So you might say, you know, are you using your mouth for sex, or is someone putting their mouth on you? Because certainly we know that gonorrhea and chlamydia can be transmitted with oral sex. And so how are they protecting themselves in those situations? How do you have sex? What parts does your partner have? These are all the questions that we would like to ask. So how do you have sex? Again, asking what body parts they're using for sex, and how are they keeping themselves safe. So I forgot, is this my slide? It is, right?
Yeah, but you guys did such a great job that we basically covered all of these things.
I know. I think it's pretty much the same things that we went over with Joe, and obviously you guys learned it all already. So good answer.
I think a couple of just highlights here. It's, you know, you have to remember that a lot of times for adolescents, they're very, you know, here and now focused, and they will forget that they've used other parts in the past. And so when we're doing screening, it's really any parts that have been used and, you know, since their last screening, as opposed to what they're doing right now. So that can just be a clarifying question for people. I've had, you know, I'll ask patients, you know, are you having sex or whatever, and they'll say, oh, no, no, no. And then, you know, a few minutes later, they say, well, yeah, in the past. I'm like, well, I knew that when I was asking that you weren't having sex right now in front of me, like I can see you, but it's just the kind of way that the adolescent brain interprets questions that a lot of times you have to be extraordinarily explicit when you ask. So it's not just right now, but it's also in the past. And then the other thing, do you protect yourself against STIs? How do you do that? And then how often? So again, adolescent brains, with developing, and they're really proud of doing something 50% of the time, which granted versus 0% of the time is certainly better. But really what you have to offer them is, you know, do you use that half of the time, or do you use that 25% of the time? Do you use that 75% of the time? So often when I'm asking these kinds of questions that may have a variety of answers, I give them that whole range so that they feel safe to say 25% of the time. And don't think that they want to, that I want to hear 100% of the time, and therefore to say, oh yeah, all of the time. So often I give them that permission by giving them choices that would be under where, you know, they should be for complete STI prevention. So this is just as a fact slide here, screening recommendations. And so just a reminder about what screening is. Screening implies asymptomatic. So this is very different than someone who's having pain, is having discharge, is having fevers, weight loss. That is not going to fall into the category of screening. And so this is truly for people who come in and say, I am fine, I have no symptoms. So recommendations vary based on risk category, and there are multiple risk categories depending upon partners, depending upon parts. But suffice it to say that at least yearly for all sexually active adolescents and young adults who are less than 25 years of age, they should be getting STI screening. For patients who are taking PrEP, which is pre-exposure prophylaxis that we're getting ready to talk about, the general STI screening recommendation is actually every 3 months. So it is more frequent than yearly. And here are all of the list of tests that may be included: chlamydia, gonorrhea, syphilis, trichomonas, HIV, Hep A, B, C, herpes. Some of these are done more often than others, and some of them depend upon community prevalence. And the final thing is that all sites used for sex should be screened. So for many, this is triple testing, meaning there's going to be 3 sites that are screened when patients come in for that screening. And one site, we've definitely picked up positivity in one site and negative tests in others. All right.
Okay. HIV screening is for everyone. Pre-exposure prophylaxis, what we call PrEP, can be used for anyone at risk for HIV infection. So the main point to communicate here with this slide is I think a lot of us think of PrEP or pre-exposure prophylaxis and HIV prevention in the realm of men who have sex with men, but I think it's important to remember that PrEP is for anybody who could come into contact with HIV. That could be people that use their vaginas, people that use their rectums. It's very minimally transmitted through oral sex. However, some people like to be safe just in case. And of course, people that might use needles and come into contact with HIV for that reason. Just going to go over a few. Okay, so someone is asking, does Title 10 or other programs cover PrEP? Yeah, they do not cover PrEP as far as I'm aware of. Insurance covers PrEP. Gilead does have copay cards, and they do have patient assistance programs for people that aren't insured and cannot afford it. But I do believe that, I know Medicaid covers it, Medicare insurance plans cover it, and I believe medical assistance programs also cover PrEP. How much is it average? So for Truvada, it is generic now, so it depends. But if they're getting a copay card and they're getting it through Gilead, I mean, it can be $2,000 a month, so it can be pretty expensive. And then you have to consider appointments for testing and screening, because you have to be seen every 3 months to stay on PrEP as well. However, it's caution. What's that?
I was going to say, for some people, really, the medication costs end up being covered by a copay card, but it's the labs that need to be done and the visits that become the bigger expense for it.
Mm-hmm, exactly. All right, so PrEP is medication that a person takes every day to prevent HIV if they're someone who could be potentially exposed. And Truvada is the medication that has been researched and studied and has been around and tried and true for the longest amount of time. So that is typically the one that's prescribed. And that is safe to use in people with all body parts. Who can take PrEP? Again, just the same as what we mentioned before. Anybody who is potentially exposed to HIV can take PrEP. Who can prescribe PrEP? Any prescriber can prescribe PrEP. It's really not hard. There are guidelines all over the internet. Gilead has guidelines. I'm pretty sure there's a lot of websites that have guidelines on it's just very algorithmic. It's just recipe cookbook type of prescribing. So it's fairly simple. It can be intimidating when you look at it, but it is pretty simple. Can adolescents under 18 years old consent to PrEP in Texas? The law is vague on this in the state of Texas, and so they say that they may. So the Texas Department of Health has said yes, they can consent based on that.
That doesn't necessarily mean that they can have the whole thing confidentially, because
yes.
Unfortunately, we can't just, those prescriptions have to be sent, labs have to be done, all of those things. So they can consent, but it doesn't necessarily mean that it's going to be, the whole process is going to be confidential.
Correct.
Unfortunately.
Yes. Does PrEP interfere with hormone therapy? I think it's really important to tell people, if you're recommending PrEP to anybody who is on hormones for gender affirmation, that it does not interfere with hormone therapy, because that will be the first thing that people will think about is this going to mess with my hormones? They're not going to work as good. So kind of giving that reassurance ahead of time is very helpful and important. It is effective in different rates depending on what body parts people use for sex. It penetrates rectal tissue quickly within 7 days, and vaginal and cervical tissue, it takes 21 days. And it is much more easy to maintain that level in the rectal tissue. So even if a person takes it 4 times a week, they have a really high level of protection from HIV if they're exposed. Conversely, if someone has a cervix or vagina, it does require a little bit better adherence to the medication. PrEP does not, as it turns out, increase rates of high-risk sexual behavior, though you might read or hear that some people say they have more STIs, people that take PrEP, and that's probably because they are being screened more often. As Dr. Monge said earlier, the recommendation is every 3 months for people that are on PrEP for triple site testing. So that's probably why that information gets a little confusing at some point. And if somebody isn't good at taking medication daily, I think probably we all have tools and ideas on how to discuss what are the barriers, what are the limitations, and what are some ways to be able to help somebody increase their compliance, such as a pill box, an alarm on their phone, and things like that.
But the one caveat to that is if you have someone who really wants to be on PrEP, the data says that 4 days a week is probably enough to prevent HIV if they're taking the medication 4 days a week. Of course, I don't tell patients that at the outset because then they hear 2 days a week. But I think that any trepidation that people may have that people can't be adherent to the medication, you need to just know that it actually is effective even if it's not 100% adherence.
I think if it's taken 2 or 3 days a week, it's about 70 to 75% effective. And so even that is better than zero.
Okay, so we find ourselves at the end of an hour, which is crazy. Obviously, we could talk about this for many hours. So if you all have any questions, you can quickly type them into the chat box like Melanie had written, or give them, shoot us an email or something at a different point. But sexual and reproductive healthcare needs of LGBTQ plus adolescents and young adults can be different than their peers, and being aware of that is really important for all of us who find ourselves taking care of these patients. Advocating for comprehensive care for them is critical for their short and long-term health. And so even if you're not a healthcare provider, but instead you're a therapist or you're a health educator or wherever you find yourself with this vulnerable population, helping them to advocate for their own needs and then understanding that really their unique needs do put them at risk for some other health outcomes. And then providing a safe, confidential, non-gendered and non-judgmental language and space allows for vulnerable adolescents to be heard and cared for, which is really what we're trying to do on a daily basis. So I love this slide. I'll leave it. This is actually from the American Medical Association, and I love it. And if I had my own office that wasn't kind of in somebody else's space, it would be posted everywhere. But signs like this, I think, are really help go a long way. There's a quick question about raltegravir and its use in PrEP. Marcy, do you?
Yeah, it is not. The only medication that is approved is Truvada, and also Genvoya has recently been approved, and but that's only for people that are using their rectum for sex. It's not approved for people that would have a vagina or cervix and are using that part of their body. So Truvada is kind of the tried and true.
We have a number of references that you will get, and thank you very much for being here.
Wonderful.
Thank you so much.
Thank you to everyone who joined us and to our fantastic presenters. We hope you have a wonderful rest of your week. Once I end this, the evaluation will pop up, and just a reminder, we will also send that out via email. Thanks, everyone.